Medicine Medical Grand Rounds. Thank you all for attending. Before we go on, I'd like to acknowledge that McGill University is situated on the unceded territories of the Kenyan Gahaga and is located on land which has long served as a site of meeting and exchange with Haudenosaunee and Anishinaabe Nation peoples. Prior to introducing Dr. Suri, our McGill and to mute and to write your comments and questions in the chat, and we'll invite you during the question and answer period perhaps to open up your mic if your questions are more detailed and of course have questions in the room. So without further ado, I'll pass the podium to Dr. Suri.
Thanks, Mark. Thanks for giving Nephrology the opportunity to introduce a speaker today. So Dr. Rémi Goupil, I've known for quite a while. We've worked together for quite a few things now. He is a very well-known Quebec researcher and Canadian researcher, really. He's an FRQS scholar, and he's an associate professor at the Université de Montréal. He is chairing co-chairing, I should say, the Canadian Hypertension Guidelines Committee, and this is what he will be presenting on today. And his title is kind of catchy: New Hypertension Guidelines and the End of Essential Hypertension, and something in nephrology we discuss all the time. So it's a topic I think that appeals to everyone. Everybody has patients with hypertension. So without further ado, I'll hand it over to Rémi. Thank you for coming.
Well, thank you very much for the invitation. It's always nice to have talks in English. Give me a bit of practice. I did in French most of the time, so I'm very happy to be here and to talk to you about a subject, well, two subjects actually that are really close to my heart. So let's just start. I have to say I don't have any disclosures. I have unpaid leadership positions, but they don't affect anything controversial that I might be saying, and I'll say when some of the opinion is not that of Hypertension Canada or other major societies. So let's go on to the objectives. I'll have a brief summary. You'll see it's a brief because I have few presentations just on guidelines, and I just want to give you an overview of what the major changes are compared to what was done before. And then we'll mostly talk about aldosterone and how it relates to what we used to call essential hypertension. First thing to say is to put in context, hypertension is highly frequent. When we look at the overall adult population, meaning between 30 and 79, it's about 20 to 25%, depending on the sex. And if you add people older than 80, it's close to 25% in the general population of Canada. So this is a major health problem. You know, you have patients who have hypertension. You know people in your family that have hypertension. At some point, I'm almost surprised people don't have hypertension in my clinic. So it's very common, but we're quite lucky in Canada because if you see here on this graph, we're in like the top percent, the second country with the lowest prevalence of hypertension. So even though it's extremely prevalent, we're still not one of the worst countries in the world. What we are the best country in the world in terms of diagnosis rate, treatment rate, and control rates. And you see here it's only 61%. That's the latest data that we have. We should have more data from the latest survey in the next few months, I guess, but I don't anticipate any changes. And my guess it may be even worse with all that happened with COVID. So all that to say, it's 60% control rates, 80% diagnosis rate. So we're still far from a perfect world, and there's still lots to do about that. And we can see in this graph that this is the percent of uncontrolled hypertension. It's quite stable for more than 10 years now. So it looks like our current strategies that hit a bit of a slag, and we need to do something else. So if we go in the past, so this is like the diagnostic algorithm for the 2020 guidelines. As you see, it was seen by family physicians that a bit too complex. There's lots of numbers, lots of ways to measure blood pressure. So high blood pressure depends on if you have specific comorbidities, if you measure blood pressure at home and with the standardized measurements or any different way. So it was deemed a bit too complex. And one of the main messages that we got in Hypertension Canada was to try to simplify this and try to give just one number to remember. It's a bit the same thing at the treatment level. There was very broad recommendations, nothing very specific, and you could basically start with anything that you want in terms of blood pressure measurement. There was still a big emphasis on health behavior management, and then the treatment decisions were really based on specific comorbidities and risk factors. There were few blood pressure threshold to initiate pharmacotherapy, different blood pressure targets depending on what was published at the moment. So again, it was deemed to be a bit too complex for primary care. And I think this is what we see here in this graph of the treatment and control rates in Canada. We see that slowly declining, or if you're an optimist, you could say, well, it's not declining, it's about the same, but well, it's not getting better anyway. So despite all our efforts and despite everything that happened in the past 30 years in Canada, which made us the #1 country in the world in terms of treatment rate, we need to do something else to get it over the hump. So this is where the latest guidelines come in. So when Greg Hundemer from Ottawa and I were named chair 2 years ago, we decided to start from scratch, listen to primary care, and try to give something at first urgently that was very specific to primary care by simplifying everything, but keeping it highly pragmatic, highly useful for this population. And then we can tackle some more specific subjects that maybe specialists would be a bit more interested in. So the first step was these primary care guidelines, which were published in Canadian various Canadian journals last year. So we're almost to the day, the 1-year anniversary of the publication of the guidelines. And this was a very hard work by a dedicated group of, hypertension specialists, but also primary care workers, meaning nurses, pharmacists, family doctors, also lots of patients that were involved, and the public also. We did some public surveys to get this right. It's a really simple methodology. We just end up with 9 recommendations. So really the basics of hypertension care, everything that everybody needs to know and needs to put into practice. We use the ADAPT process, which is a process that lets us take the literature review that was done by prior guidelines, adapt it locally to the Canadian context and to the latest publications since then. And we use the grade recommendation to try to harmonize everything with all the other guidelines that are recently published. For every guidelines, you could read the document. There's obviously a scientific rationale, some evidence table that are available, but also we dedicate a bit of space to what the values and preferences of the committee was. Because as you know, the data is the same. It's just the way we interpret the data and what we feel is important. So it's important to showcase how we interpreted the data and what were our values and preferences for each of these recommendations. And as you'll see in a few minutes at the end, we came in with some very pragmatic algorithms that use these guidelines, and they apply what we call the HEARTS framework, which I won't go into details, but it's a WHO program that was implemented across the world, and that showed very, very high control rates in hypertension in specific jurisdictions. So let's go down to the recommendations per se. The first one is really how you should measure blood pressure, and it's really simple. You need a validated automated device and a standardized method, okay? So there's no more place for manual measurements. There's no more place for non-standardized measurements. You need to measure blood pressure correctly. That's it. There's no way to do it otherwise. Second recommendation is still an importance to check the blood pressure outside of the hospital settings or the clinic settings, because lots of people have white coat hypertension. So you want to confirm the diagnosis outside of the office. And the last one is a major change in Canada. So we changed the definition of hypertension. So you remember the first figure, it was various numbers, but here it's one number. So if you have high blood pressure, if you have blood pressure above or equal to 130/80, and it's confirmed at home and it's measured correctly, you have high blood pressure. Okay, so these are really strong recommendations with always a moderate certainty of evidence. So what's the optimal blood pressure measurements? I think we keep telling everybody this for many, many years. It hasn't really changed. I do a lot of work trying to simplify this procedure because, as you see, there's about 30 steps to do it. It's very hard to implement in clinical practice, but it is possible. We do it at my hypertension clinic. There's some, I would say, cheats that we can use, but basically this is what you need to do. So important of having a position, rest period. If you measure the blood pressure at 2 to 3 times in a perfect world 3 times, and then with at least 1 minute rest, up to 5 minutes rest, and you record all the averages and the values. So this is the correct way to measure blood pressure, and you have to use this technique to apply all the numbers that I will give you. So it gives us a very simple algorithm, which is really focused around just one number, okay? So if you measure blood pressure correctly and it's below 130/80, you don't have hypertension unless you have masked hypertension. So it's still important to check blood pressure at home, especially for high-risk people. But if it's a bit high, you check it out of office, and it can either be the home blood pressure measurement series or the ambulatory blood pressure measurements. And for that, we use the average daytime measurements, and this corresponds to the same 130/80. If you have high blood pressure at the office but not at home, well, you have white coat hypertension. You still need to follow up. You're at risk of developing persistent hypertension, but basically you're not, there's no indication of treating white coat hypertension. So really simple algorithm that can be learned with just a quick check rapidly. So just one number. And then we go to the treatment recommendations. Healthy lifestyle is still the #1 recommendation. It's for everybody with hypertension. So if you have 130/80, it's confirmed at home, it's measured correctly, you need to maximize your healthy lifestyle to try to get this blood pressure down. For the pharmacotherapy, then it depends a bit on your risk, okay? If everybody has a blood pressure above 140/90, we start immediately pharmacotherapy. We don't wait for lifestyle changes to work. And if there's some high-risk condition, then it's when the blood pressure is above 130. So as soon as you have a diagnosis, you start treatment. And again, simplify everything, but make it evidence-based. The target for everybody is to have a systolic blood pressure below 130. There's no target for diastolic blood pressure because now we know that diastolic hypertension, meaning that when the diastolic is above 80, but the systolic is below 130, there's no risk associated with that. So if there's no risk, there's no reason to specifically treat this condition. You still need to keep an eye on these people. They can progress to systolic and diastolic hypertension. These high-risk conditions I mentioned for the threshold, the lower threshold for initiate the pharmacotherapy are listed here. Nothing really surprising here. So it's basically you have cardiovascular disease, diabetes, any type, chronic kidney disease, either by biology, FR, or presence of albuminuria, a high Framingham risk score, or advantage. So nothing really surprising here. It's been expanded from the last definition of the 2020 guidelines because we have lots of new data on intensive blood pressure treatment. And then when you need to initiate pharmacotherapy, what should you use? So the first line is now a low-dose combination therapy. So you start with 2 medication in 1 pill, and it needs to be a combination of ACE and ARBs or thiazide-like, or long-acting CCB. So 2 of these 3. As you know, there's few options in Canada for combination therapy. It's mostly ACE and ARBs and thiazide-like diuretics. The other ones are a bit too expensive and not covered by our system. So first line, low-dose combination therapy. We know there's good data and there's good statements that were made by various institutions now that demonstrate that low-dose combination therapy as an initial treatment, you get better blood pressure response, you get better hypertension control, you get less side effects, you get less morbidity and mortality with that. And it's not, most of the time it's not more expensive, it's even less expensive. So there's really good combination. Almost everybody with hypertension will need low-dose combination therapy anyway. So if this doesn't work, you're still above target with this low-dose combination. Well, the combination is the 3 medications that you should use in these low-dose combinations. So that's not too hard. And the next step is spironolactone. So this is just a conditional recommendation because there's no hard outcomes data with spironolactone in resistant hypertension, but it's the best antihypertensive agent, meaning that it's the one that drops the blood pressure the most. So keep that in mind for the next part of the presentation, because we'll go back to aldosterone and all that. So as you can see, it's quite simple. Now it's intentionally small. We can zoom in a bit. So this is an algorithm that we developed using these guidelines, okay? Using these recommendations. These are not the recommendation per se, but they use everything that's written in the guidelines to provide an implementation tool that can be easily accessible and easily used for almost everybody with hypertension, okay? Obviously, it's not to be used in pregnant women and children also. And always use your clinical judgment. Some old, frail people, you need to be much more careful when you reduce hypertension. You may want to be less aggressive when you reduce hypertension. So you need to be careful with that. So always use clinical judgment. But if we stick to the first part, it really says what we told you. So when you have a diagnosis of hypertension, everybody needs a target below 130. So you either don't have high-risk condition or don't have the blood pressure that's high enough, then you go just to healthy lifestyle changes and you reassess regularly, because these people, most of them will eventually progress or develop a high-risk condition. If they do, or if they are in this section first, so a blood pressure above or equal to 140/90, or systolic above 130 with a high-risk condition, then you initiate lifestyle changes and start pharmacotherapy. And this is a bit the controversial part, the one that we got the most comments by experts, but that was the most appreciated by family physicians, is we give what to do. This is a recipe. It's one of many recipes, but this uses the guidelines, and it's a recipe that was selected for many reasons. The first one is the availability of the irbesartan HCT, the possibility of cutting the pill, the fact that it's 9 companies of generics that manufacture this in Canada, and that it's on the essential medication list of Canada. So there's many reasons why this one was chosen. None of these reasons are due to conflicts of interest or anything from the committee. So it's a very potent and widely available and cheap medication in Canada. So as you see here, we start with the low dose of half tablet of this irbesartan HCT. We double the tablet if it's not enough. Then we add amlodipine, we increase it to 10 milligrams. And then in the fourth step, when we get into the range of resistant hypertension, this is where we add low dose spironolactone, which can even be increased a bit higher. At any point in this algorithm, if there's concerns for secondary cause of hypertension, there's always a good reason to refer to a specialist. So really, there's a lot of change in the 2025 Hypertension Canada guidelines, and nothing of this says that what was done before was bad. It was very good. It was incredible work, but lots of my colleagues, people I know, and it worked quite well, and it made Canada the best in the world. Why we changed that? It's not because what was before was not working, is that we want it to work even better. So we feel that by using a simplified approach, a pragmatic approach that is really evidence-based, and that was asked by family physicians who treat 95% of hypertension in Canada, we could achieve or hopefully go closer to the 80 to 85% treatment rate, control rates in hypertension. We'll see if this happens, and we'll adjust everything in the following years if needs be. But we believe it's a good strategy to try to go to the next level. So all of this was for essential hypertension, okay? And if we go back to one of the original statement, what is essential hypertension, okay? Do we use this in every patient? And as you see, it's not as clear as it should be. So why do we call it essential hypertension? So if you take a minute or two to read these quotes from about 60, 80 years ago, 100 years ago, it shows that before people thought that hypertension was essential. It was a compensatory mechanism that was essential for living, that the blood pressure needs to increase itself to make sure there's perfusions to the organs. And here I find it funny that mild benign hypertension was defined as blood pressure below 210 over 100. So really, we're not in the same world, and it took a lot of time to move away from these terms. And the term essential hypertension comes from there, and it stayed because of that, because we used to use this term. So we went, and I won't show you the data because they're quite obvious, but we went from something that's essential, compensatory, that's needed for life, to the silent killer. So really, there really was a big shift of how we see hypertension now. And we're really trying to move away from the term essential hypertension and try to use primary hypertension, meaning that it's not secondary hypertension. There's no specific cause of hypertension. But this is really the first way to move away from essential hypertension, but let's move away from primary hypertension too. So the traditional view of primary hypertension was that, well, almost everybody has primary hypertension. There's really only specific patients who have specific conditions or manifestations that have secondary cause of hypertension. The perfect example of that was primary aldosteronism. So primary aldosteronism was almost unknown until the mid-90s. And then there was a wide availability of the aldosterone to renin ratio test, where we can measure if there's some renin-independent increase in aldosterone. So this increased the prevalence of primary aldosteronism, but it's still to this day seen as a relatively rare cause of hypertension, where you need severe hypertension, hypokalemia, and most of the time an adrenal nodule or at least an hyperplasia. Now, more modern view, we know that primary hypertension is less than 80%. And if we include obesity, if we include sleep apnea, if we include chronic kidney disease as a secondary cause of hypertension, really primary hypertension doesn't really exist anymore because most people have those risk factors. So they are related to these conditions. And most of the time they are caused, at least in part, by these conditions. So really secondary cause, when we systematically screen for them, they're at least 50% present most of the time. And again, perfect example is primary aldosteronism. Well, now we know that it's present in people with normal blood pressure, with normal potassium, and with normal appearing glands. So we go from something that's very rare or uncommon to something that, as you'll see in the next few minutes, is very common. So let's go a bit into primary aldo. So what is primary aldo? So it's a renin-independent secretion of aldosterone by the adrenal gland. It's something that's unregulated, or at least not as regulated as it should be. So what does aldosterone do? It binds to the mineralocorticoid receptor in the collecting tubule, and this increases sodium reabsorption. So you get more salt, keep the salt in the body, it increases the blood pressure, and it increases the excretion of potassium. So some people get hypokalemia. And this starts a loop, an amplification loop, where since there are more sodium in the body, the volume is higher, you get more sodium reabsorption in the proximal tubule, and you get blunting of the renin-aldosterone-angiotensin system. So the renin is always low. It's a sine qua non of primary aldo. The renin is always low, okay? So you get this here. And this altogether, it doesn't only increase blood pressure, it's also a major comorbidity. And it is quite frequent. So here's this table from the latest guidelines. As you can see, there's lots of studies that looked into the prevalence of primary aldo. Some of these, they weren't systematically screened, but we can see various numbers, but it's certainly not the 1 and 2% that we initially thought. And when we take all of this together, we say there's about 15% of people in primary care that have overt primary aldo. So really, they have definitive primary aldosteronism. And when we look at referral centers, it's more than 30%. So in my hypertension clinic, it's probably 50% primary aldosteronism. So it's something that's very common, and I can quite assure you that everybody has at least a few in their clinic, whatever their specialty, okay? And like I was saying, there's an added risk of primary aldo. So let's say you have two twins, they have identical twins, the same blood pressure, they live the same life, they have the same comorbidities and the same environment. If one develops a somatic mutation in the adrenal gland and develops primary aldosteronism, this twin will have 2 to 3 times higher chances of an MI, heart failure, stroke, AF, left ventricular hypertrophy, and kidney problem. So really, primary aldo itself, independent of all the other comorbidities and of blood pressure, is an independent risk factor for these conditions. And why does it matter? Is because we can treat it. Okay, here's a graph of the incidence of MACE events across the years. And the first, well, let's start with the blue line here. It's essential hypertension. So this is basically the baseline risk of everybody with hypertension. When you compare to primary aldo patients who had adrenalectomy, you see you get this screen way down hypertension. Why? Because lots of these people, probably half of them, will be free of hypertension. They get cured, okay? We have a potential curative intervention here in these patients. So this is why you get so low risk of these patients. But when we look at these are patients who are medically treated in the red line, and we see there's really a residual risk there. So there's a problem. We're treating it, but maybe we're not treating it enough. And this is what the next slide shows. So again, the blue line here is the essential hypertension. The red line here, which is about the same as we have here, is the people with PA who are treated with MR antagonists, but we still have a suppressed renin. So a suppressed renin, it means that the aldosterone is working too much. So it means that the treatment is not enough. And when we look at people who have unsuppressed renin, they have the same risk of hypertension. So we really eliminate this added risk associated with primary aldosteronism. So that's why it's important to identify these patients and treat them appropriately. And again, it's not a rare condition. So this is a very nice study that was published a few years ago from Boston, where they did really saline suppression testing in people who didn't have PA, who didn't have primary aldo. So this test really sees if you can suppress the aldosterone secretion when there's hypervolemia. So normal conditions, aldosterone is really down when you give saline to patients, okay? But in these 4 different populations, included normotensin and low-stage hypertension and resistant hypertension, you see that the rate of people who have abnormal aldosterone secretion following a volume stimulus, there's still like 10, 15, 20%. So it's very common to have a primary aldosteronism physiology, even if you have normal blood pressure. And also a big problem is that it's there, but we don't look for it. There's lots of study right now, and one that I participated in with using ICES data in Ontario, that showed that if we look at all the people in Ontario who have high blood pressure and hypokalemia, only 1.6% had aldorenin testing. So really, it's something that's either for many reasons that we don't look for when it's there. So hypertension and hypokalemia, they probably 30% have primary aldosteronism. So it's really frequent in this population to have that, but we don't even test we test in less than 2%. It's the same thing in resistant hypertension, where there are clear guidelines that say that we should look for primary aldo. And sleep apnea is a bit more controversial, I would say, but there's still very few people who have aldosterone renin testing in this population. Like I said, there's many reasons why. There's certainly not one reason why. I think the main one is people perceive that it's complicated to do the PA workup. And this is what from the 2016 guidelines, which was the same as the one in 2012. As you see, there's several steps. You need to identify patients who are at risk of having the condition. You do aldosterone to renin ratio in these patients under specific conditions to screen, and then you need to confirm with another test, and then you do a CT, you do a adrenal sampling. So as you see, there's many steps to having a correct diagnosis of primary aldosterone. So in 2025, they decided to simplify all of this, but I think they failed. It's much more complicated now because they wanted to remove some of these steps in different patients. So it's something that nobody can learn. Nobody knows what to do unless they read each of the steps and they go down each of the steps. So it's still really complicated. And they tried to remove this step of having suppression testing, but really they identify conditions that almost everybody has that would need suppression testing when there's no good data that it's helpful. So we at Sacré-Coeur, we don't do any more suppression testing. We just do screening and to go directly to medication or adrenal venous sampling if we feel there will be benefit from surgery. So really there's still a lot of work to do to try to make primary aldo simple to diagnosis and to treat. But I think it's important to remember that PA, overt PA, it's really the tip here. It's really evident in the most severe phenotypes. So either hypokalemia, resistant hypertension. So in these populations, only 2% are screened. But like every disease, it's a continuum. Some people have very mild disease, some people have very severe disease. But we know that if we go down this continuum, it remains a problem. And there's a population here that I have lots of interest in, and I published a few things on. It's called subclinical PA. So these people with subclinical PA, they have renin-independent aldosterone excess. Okay, so they have a PA physiology, but they don't have features of PA. Most of them have normal or very mildly elevated blood pressure. They don't have hypokalemia and really don't have specific criteria to screen for PA. So it's really a population that's hidden in the general population. And we did a bit of work to try to identify, are these people at risk? Or is it just something that they don't have the disease yet and it will come one day? And I'll show you a bit of our data. It's not the only data, okay, but it's our data. So I'll show it to you. So we use the Cartogen database. So I hope most of you know the Cartogen database. There are like 20,000 patients from Quebec that were enrolled in 29 and 2010 that had all sorts of tests and blood tests and samples. And they're followed using the administrative health data. So we use data from 1,200 of these that had a follow-up with when they participated in the Canadian Alliance of Healthy Hearts and Mind, where they all have repeat blood tests. They had MRI or the brain, heart, abdomen, and blood pressure measurements. So we use this data to see what happens to people who have PA physiology without overt PA at baseline, what happened to them a few years later. And what we see here, I'll just summarize it by saying that people who have this subclinical PA phenotype, they have worse they have worse cardiac remodeling. We can see that they have a bit higher left ventricle mass index. They have a bit more ventricular hypertrophy. That's true for the overall cohort, but also with people with normal blood pressure. Okay, and then when we look at arterial stiffness or central blood pressure, we see the same patterns. So people with high aldosterone, low renin, or high aldosterone to renin ratio. So this is a subclinical PA pathophysiology. We see that they have worse arterial stiffness and that they develop more hypertension in the future. So this is not really surprising, but it's been shown we just show it with Quebec data. And then we say, well, let's look at the heart outcomes. What happens with heart outcome with this physiopathology? So again, remember that this is a general population Cartogen. People are relatively healthy. They're really representative of a normal population. So most of them have normal BP. If they have high blood pressure, it's quite mild. There's very low cardiovascular risk. So we see in this that aldosterone doesn't change much, but people with low renin, which is bad, they have, well, here it's the inverse because it's high renin. So when they have low renin, they have high risk. When they have high aldosterone to renin ratio, they have much higher risk. And we see that it's a non-linear relationship for renin. So the lowest renin is associated with the highest risk of major adverse cardiovascular event. We see the same thing with, well, not the same thing. We see a similar pattern of increased risk with aldosterone to renin ratio, but it's not something that's seen with when we measure just aldosterone. So really renin is driving the phenotype. And we tried to define some cutoffs where this, like a cutoff for renin, and we now wind up with 4. So when the renin is above 4, the risk is much higher than when it's less, when the renin is less than 4, the risk is much higher when the renin is above 4. And the aldosterone renin ratio is 70. Just to give you an idea, in the new guidelines, the aldosterone renin ratio that would say that you would probably have PA, it's 110. The prior guideline was 150, and the renin is 6 or 8. So it's really much lower than what we would call PA. And we're nephrologists. We like to see what happens to the kidney. So we used, again, this data to see in the future. And we can see that, again, the higher aldosterone renin ratio, the steeper the eGFR decline, okay? So people will lose kidney function faster. These are small numbers, yeah, but it's still excessive compared to what we would see with normal physiology. Renin, the same thing. So the lower the renin, the steeper the decline. And again, no association with aldosterone. We tried to see the impact of albuminuria, but as these people are very low risk, most of them didn't have any significant albuminuria. So we didn't have data for that. So I think you know where I'm going. Subclinical PA, it's quite frequent. I would say that everybody with low renin have subclinical PA, as long as they don't have overt PA. So this is about 30% of primary hypertension. It's about 50% of resistant hypertension. Okay, so lots of people have this phenotype. So we see this in the graph. So overt PA, about 25% of resistant hypertension, but subclinical, we probably get another 50%, then 30 to 50%. In all hypertension, we see that probably half of them have some sort of aldosterone dysfunction. And even in the general population, we see a lot of this phenotype. So really, it's a tip of the iceberg situation. If we see that diagnosed hypertension is really the top, we have a bit more over primary aldosterone and subclinical PA here. So full disclosures, I used AI for this figure, and it keep telling the chatbot to make the bases larger and larger and larger. And at one point, I just stopped because we wouldn't see the tip, because that's the size of the problem here. Yeah. So there's what do we do with that? And there's a few cases to be made. The first one is, well, let's screen for PA everywhere. There's good reasons. Some bad, but mostly good. I think the best reason is, well, the disease is there. So if we don't look for it, we can't provide the proper treatment for it. So that's I think, the main reason. The test, everybody say, oh, it's complicated to get AR done. No, it's very simple. They do it at every hospital. Really, the CLSCs before, they were doing the test. Well, I mean, taking the blood for the test, but now it's changed the past year. So maybe there's a bit more problem here. It's not cheap, but there were some studies that show that it's cost effective because we identify disease where we can address specifically and then reduce the adverse outcomes with that. And also, I think we need to change what we're doing because it's a catastrophic failure. If we have a disease and 2% are screened, well, it might as well be 0. And again, I've shown there's disproportionate cardiovascular harm with undiagnosed PA. There's potential curative treatment for those who can operate, and there's highly effective and very cheap disease-specific treatment for the other ones. So in the past year and a half, things have changed. So we got the Endocrine Society in their PA guidelines that suggests that screening should be done in everybody with hypertension. The ESC came up with the same suggestion a year before that. And then the latest ACC/AHA guidelines of last summer, they again suggest that, well, we should consider screening in stage 2 hypertension. So this is basically above 140 over 90. In Canada, we're working on it. I can't say what will happen. I think you can guess because I'm the co-chair and I'm speaking here, but it's not just up to me, so I can't say anything really. So, but we're working on that. It's something that we really want to evaluate if it's worth it to do that. And then the second case is not, well, let's just treat everybody, really. Why go through all of that? My argument was say, well, you would deny the curative treatment for lots of people. That's, I think, something interesting. But if we look at meta-analysis data, and there's very few data, but if we look at these meta-analysis, where there was a study that compared MRA, so mineralocorticoid receptor antagonists like spironolactone, to diuretics and to ACE and ARBs, it showed a tendency toward a more potent antihypertensive effect. That's as first-line therapy. So we have a bit of data here, and this is in resistant hypertension. So this is a famous figure in hypertension from the Pathway 2 trial that assessed the best fourth-line medication in hypertension. And this is basically, so the red lines here is the antihypertensive effects of spironolactone. So you see this line is clearly below the other ones at just until the renin is very high, okay? So almost 1,000, you never see that. Well, it's probably 600, 700 here, but it's very uncommon to have renin this high. So basically at all level of renin, especially when it's low here, you have very potent effect of spironolactone. So again, there's an ongoing conflict that I'm living every day. Should I apply the guidelines, which are evidence-based or made to be used? They're pragmatic now. There should be work. They should work in everybody. But then there's a physiology-based practice saying, well, PA is probably there or aldosterone dysfunction. Should I more go with the physiopathology-driven perspective and try to personalize care? And I think more and more of the studies, and we're working on one right now, are going to this way. Instead of saying, well, use whatever drug you want, we try to phenotype somebody and try to select the drug that may be the most potent. And this is my approach. So this is not endorsed by any major societies except the Goupil societies. I basically screen everybody with hypertension, whatever the severity. As soon as they come into my office, they get AR testing. This tells me what to do afterwards. If there's no suprarenin there, I'll apply Hypertension Canada guidelines without thinking about it. If there's a phenotype that's very suggestive of PA, overt PA, so meaning a low renin with a ratio of aldosterone renin ratio that is high, I do the full PA workup. So we do adrenal venous sampling at my hospital. There's a very long waiting list now, but it's always successful. So that's why we have a long waiting list. And if it's something in between, meaning that the renin is on the low side, there's no specific reason to think PA is there, I tend to try spironolactone. It usually works quite well. Certainly doesn't work less than other blood pressure medication. And then I keep an eye on those. I try to stop the medication if I can. I do rescreen and all that. I see if the aldosterone creeps up even under spironolactone, and then I can put them in full PA workup if I feel they may have developed overt PA. So this is a more physiology-based practice. So let's end with a few take-home messages. So as you remembered, I presented to you the new approach to hypertension care in Canada. So there's a few major changes here. So automated office blood pressure measurements is really the way to go. Forget about manual measurements, forget about non-standardized measurements. There's a new diagnostic threshold, which is much lower than what it was before. We use the Cartesian data, and our paper should be out very soon. And we showed that there's about 9% absolute increase in hypertension diagnosis in Canada, but only 1 of 6 of these people, and they all have high-risk features, would need pharmacotherapy. So really it's naming a disease that is there and focusing on healthy lifestyle changes in the population. And again, the risk will define if we treat with pharmacotherapy at first, try to think combination therapy first line. It's really the way to go now in all the major guidelines, single systolic BP target of 130. So this really basically summarize the new guidelines. And then I would say my message would say, let's stop using the term essential hypertension. Let's start using primary hypertension, but let's make it a diagnosis of exclusion. So if you want to exclude other diagnoses, you need to look for them. And the most appropriate test, or the most bang for your buck test, would be aldosterone to renin ratio in all patients to try to exclude primary aldosterone over PA or just subclinical PA. So think PA early. The best way is always when the patient comes in and doesn't have any medication, because you don't have to think about the effect of these medications on the ratio. Low renin identified an aldosterone-driven phenotype, and in these patients, I think it's good to consider MRI very early, but we're starting a study to look into that specifically. So this is it. I hope you had a good time, and I'll answer your questions.
Thank you, Rémi, for that very nice overview of the guidelines. We'll go to the chat now. So maybe I'll read some of the questions. If you're not controlled on low dose combination, would you increase the dose first, or do you go right away to triple combination all at low doses?
So it will be more potent to go to the triple combination at low dose first. With the guidelines, we went to increasing the dose of the combination first, so the two drug combination first, just to make it easier for family physicians and all that. But if we look at the data, it's a bit more potent to use 3, 4, 5 low dose medication than 2 at full dose.
Okay. And then there's a question about measuring devices, these new cuffless measuring devices, and some physicians are even wearing them. What do you think about those?
Yeah, so we at Hypertension Canada, we wrote a statement on that 2 years ago, I guess. And the basic message was the same as everybody. It's not ready. You can't use them, okay? It's not accurate enough. It can give you clues whether the blood pressure is high, okay? But never rely on these cuffless measurements to make treatment decisions, okay? The Apple Watch is a good example. It can give alerts to that the blood pressure is high, but you wouldn't use that alert to start treatment. It would use it to measure blood pressure, make sure that the blood pressure is indeed high. And I think it's important to tell the patient, it doesn't mean that the blood pressure is normal if you don't get these alerts, okay? It doesn't forego the need to systematically screen everybody.
Okay. And then the next set of questions has to do with the actual measurement of the ARR. And, you know, if patients are already on spironolactone, you have to stop that. Yeah. I've had patients where trying to stop the spironolactone is very difficult. What are your thoughts on that?
Yeah, some people it's hard to stop, especially those are severe hypertension. I would say that if the phenotype is that severe, you'll probably be able to find primary aldo. Most people on spironolactone will still have renin suppressed and high aldosterone, so you can make a diagnosis. In an ideal, you would want to stop that and accept that maybe during the testing, the blood pressure will be maybe not as perfect as you'd like. When I came back from fellow, I was systematically changing all the blood pressure medication to use non-interfering drug. And with time, I saw that it's maybe not necessarily. And now we get, well, at least the Sacré-Coeur, we get the result quite quickly in 1 or 2 weeks. So we can make treatment decisions quite quickly if we want to stop medication. But if it's hard to stop Spiro, I would say, well, stop it at least 2 weeks, ideally 4. Buy a bit of time with some of those non-guideline drugs like clonidine or anything like that, that wouldn't affect as much the ratio, and then hope for a definitive answer when we get the results back. And as soon as they do the blood test, put them back on Spiro.
And I guess as a follow-up to that, so let's say now your ratio meets criteria for renal vein renin sampling, and you have a long waiting list, which happens in our hospital too. And now they're off spironolactone for a long time, and with patients walking around with 180 on 4 drugs. What do we do there?
There's some data now that shows that it's probably okay to do the sampling on Spiro. I wouldn't do it. because I don't want to put the patient through the test and have an inconclusive test. But for some specific cases, you could always try it. I try to plan the sampling, and I tell the radiology, well, you have to schedule it at least a month in advance so they can stop the medication. So at least they get treatment for a few months during the waiting time. Or I mean, you can start other drugs. It may be not the most effective drugs, but you can get the blood pressure down in all of these patients, really. It's just that they would need more drugs, and there's not disease-specific drugs.
And then the next set of questions relates to the standardization of the assays. Is it the same all over Quebec? Can we get it anywhere and trust that result?
Well, there's a lot of variability in interperson and intraperson variability in the tests. So that's always a big problem. So even if the methodology is the same and the accuracy of the test is the same everywhere, there's some variability person to person and day to day in the same person. So I think if you get a test that's in the gray zone, it's always good to do it again. I would always assume patients have PA, so I would put them on Spiro quite quickly, even if the test is not as conclusive. I won't put them through the whole workup and all of that. But I think too much has been put into like the conditions of the test. Just do the test. Don't worry about sitting, standing, and all that, the things that you need to check when you order the test. It's not important. The only thing that's important is that the patient wasn't in bed for 2 hours, where you don't get these conditions in outpatient settings. So that's the only thing that's important. But apart from that, don't worry about the measurements conditions.
Okay. And I have a question. So you mentioned at the beginning of your talk that there probably is no such thing as primary hypertension. And, in the literature that there's this theory about low nephron mass causing hypertension over time. A lot of patients now are being discovered to have, well, they always had, but now we're looking for it, actual CKD, proteinuric, GN, IgA, etc. So I'm just wondering how many patients, or do you have data on the percentage of patients who have coexisting primary GN in that primary aldosterone cohort, and how do you know which one is the cause of their hypertension?
I don't have data. My experience, I don't see a lot who have both of them, and I see hundreds of patients with PA. But I mean, like you said, you have to look for it. People with hypertension should have a creatinine measurements, and they should have albuminuria, and they should have a urinalysis. And you would exclude GN in these patients if everything is normal. So there's a basic workup to be done in all of these patients with hypertension, whatever the severity.
Yeah. And we get a lot of referrals for CKD and hypertension that don't have even a simple urinalysis. Forget about urine albumin to creatinine ratio. So just a little plug, don't send us a consult without a urinalysis. It's like sending a patient to a cardiologist without an ECG. Any questions from in the room?
With this approach, we end up waiting until 25% of Canadians have developed hypertension, and they are eating 10 times the salt they need. What promises is there in trying harder to teach patients how to restrict their 10 times to excess salt intake?
Yeah, it's hard. I mean, most of the disease wouldn't exist if we had perfect lifestyles. Obesity, well, I don't want to say it's always about lifestyle, but a big proportion of these diseases, obesity, diabetes, sleep apnea, hypertension, they would be much less prevalent if we had perfect habits. It's a lot of work to try to get the people to change their habits, and I don't think the government does much. My hope was that by labeling the new labels in the food, like high sodium, high fat, would help, but I think there was studies that showed that maybe not. But I think it goes with education initiatives, constant messaging about salt, and also regulatory initiatives to reduce salts in the food and put potassium salts, which would be good for hypertension, maybe not as good for patients with advanced CKD, but very good for hypertension to use potassium salts because they've been shown to reduce hypertension and have a good reduce the adverse events. So it's such a big problem that needs to be addressed. But I think in the past years or decades, we showed that it's very hard to do. There's some countries, I think in South Africa, they drastically reduce the amount of salt in the food. And they've shown that the adverse events, cardiac adverse events, the decrease in the population level. Can we get there? And we need to do that. Is the problem as worse here? And also, I don't have the answers, but it is important.
Okay, I think we have time for two more questions. So George, and then Chair Prerogative, Mark will end.
Thanks. Very interesting. I was wondering if the data are very interesting about the aldosterone and renin, where the aldosterone didn't sort of predict as much as the low renin. Is that because the aldosterone is not a good test and there's a lot of variability? Or is there something about renin that it does that's protective at a higher renin? There's a renin receptor, there's angiotensin, missing, so on.
Yeah, these are good questions, and I have a few thoughts about that. I don't think I have the right answer necessarily, but my feeling is that renin, when there's MR overstimulation by aldosterone doesn't need to be high to do that. Okay, there's some just overactivation of the MR receptor, and this leads to hypervolemia and decreased renin. And this blunts a bit the increase of aldosterone. So my feeling is that's a very early manifestation of primary aldosteronism. Maybe we should rename the disease to low renin hypertension and things like that. So I think it's probably in my view, an earlier phenotype, but it's probably not as simple as that.
You have the same, for example, with high renin, high angio, as hypertension, like renal artery stenosis, other data.
Yeah. Well, most people with like renal artery stenosis have normal renin and aldosterone. So I don't know why some people have high. It's probably just a chronic perceived hypovolemia by the kidneys. But high renin doesn't appear to be toxic. It's even life-saving when there's hypovolemia and like diarrhea or things like that. So doesn't appear to be a toxicity of high aldo and high renin when it's appropriate. But when there's a discordance between the two, that's where the problem is.
Okay, Mark, and then you would like to.
Excellent presentation. Thank you, crystal clear, and appreciate the emphasis on simplicity for not just family physicians, but others as well. And just purely from a public health perspective, since this is such a common condition and a silent killer, and we do have major issues with access to family physicians in Quebec, do you think there should be regulatory changes that allow pharmacists to make the diagnosis, pharmacists to initiate treatments?
I think so, yeah. I mean, within certain parameters, it's not a complicated disease, really. I've shown you, there's some specific tests that you need to do, but really everybody can diagnose hypertension, even especially these automated machines now. You don't need to know how to pump the auscultatory device and all that. So it's very easy. Now with the new regulations in pharmacy, at least now they can adjust the treatment. They can initiate new drugs. They don't have just to increase the dosage that the drugs that they have. So they can have these initiatives that will improve blood pressure control by initiating new drugs. And this was the thought around this algorithm is not just for family physicians. It's also for pharmacists. It's also for nurses, there's practitioners. So they can have tools without always relying on the doctors to have the treatment decisions. So in an ideal world, the pharmacists will start to use these algorithms and get the patients controlled and maybe eventually get new diagnosis if they're allowed to do these. But there's really regulatory barriers to diagnosing in Canada. There's good and bad about it, but I think hypertension could be the case study for what to do with these new potential new rights for pharmacists.
But for now, they don't get remunerated for it.
Right.
That's the barrier.
Exactly.
Because if they're gonna take the proper blood pressure measurement, they're gonna charge the patient, the government's not paying.
Exactly. So that's I understand one of the crux of the negotiations, who will pay for that. And
Thank you so much, just for
thank you.